Chief Instructor Dr. Vinita Prakasam. Right.
Good morning, all of you. A warm welcome to all of you. Our IC is on diabetic macular edema. Considering the prevalence of diabetes in our population, diabetic macular edema is one of the most commonly encountered scenarios in our retina practice. And although we have a lot of protocols and trials evaluating DME, the clinical situation varies most of the time, depends on patient compliance factors, economic factors, and many other factors. So, here we are actually discussing a systemic approach to the evaluation, the investigations, and management in a case of diabetic macular edema. Our first presenter is Dr. Sharath. He will be discussing on OCT, the quantitative and qualitative analysis in a case of diabetic macular edema. Over to you, Dr. Sharath.
I thank Dr. Vinita for the chance. Today I'll be dealing with OCT, qualitative and quantitative analysis in DME. OCT plays a very important role in managing DME, from identifying the disease at a very early stage to predict the visual prognosis and to monitor the treatment response. First thing, when you see a DME, see whether it is a tractional DME or a non-tractional DME. Tractional DME surgery comes the mainstay of the treatment, and a non-tractional DME, look whether it is a center involving DME or a non-center involving DME. Center involving DME is defined as any retinal thickening and the center 1 millimeter subfoveal zone. Center involving DME, anti-VEGF injection stays the mainstay of treatment. If it is a non-center involving DME, you can either observe the patient or can do a focal laser. Morphologically, diabetic macular edema is divided into a spongiform edema, cystoid macular edema, and a serous detachment. With the breakdown of blood retinal barrier, fluid starts accumulating in the outer plexiform layer in small cyst. This is termed as spongiform edema. With the further disease progression, more fluid start accumulating in the outer retinal layers. These small cysts coalesce to form larger cyst. This is termed as cystoid macular edema. With the further disease progression, more fluid will get accumulated, and this fluid break the ELM and go to the subretinal space, causing a serous detachment. Further, if patient is having hypoalbuminemia, increased hydrostatic pressure can lead to more fluid accumulation in the subretinal space. So the morphology, with the morphology, we can assess the severity of the disease and some clue regarding the systemic condition of the patient. Hard exudates are lipoproteinaceous material deposited in the outer retinal layers. In the OCT, they appear as hyperreflective dot or clump echoes. Usually, they are more than 30 micron in size, and they will have a back shadowing. These hard exudate slowly get absorbed with treatment, anti-VEGF injection or focal laser. Usually, they very well clears with focal lasers. If not treated, these can form clumps and migrate to the fovea, or can transform to cholesterol crystals and can cause permanent visual loss. Another OCT biomarker is intracystic hyperreflective material, or ICHRM. It's not only the fluid that get accumulated in the extravascular space, also along with the fluid, fibrin, macrophages, heme, protein, etc. will be transferred from the intravascular to the extravascular space. These get accumulated within the cyst. They appear as hyperreflective material located within the cyst. These are called intracystic hyperreflective material. If the cyst is partially filled with the hyperreflective material, usually they respond well with the treatment. If the cyst is completely filled with the hyperreflective material, usually the response to the treatment is less. Then these hyperreflective retinal foci, they are actually activated microglia cells. They appear as hyperreflective dot echoes within the inner retinal layers. To differentiate from the hard exudates, these HRF are very small. They are usually less than 30 micron in size, and usually they do not have any back shadowing effect. The presence of HRF indicate that the disease is more common, more of inflammatory mediated than VEGF mediated. So these patients will respond well with dexamethasone implant rather than anti-VEGF injection. Disorganized retinal inner layers. This is a negative biomarker for visual prognosis. This indicates that there is macular ischemia. In OCT, drill can be identified with there won't be a clear demarcation between the retinal layers. The presence of drill indicate a poor visual prognosis to the treatment. Another two indicators of chronic chronic diseases, pearl necklace sign and ELM and EZ discontinuity. Pearl necklace sign, there's hyperreflective material are arranged in a continuous ring-like pattern around a cyst. This indicates a chronic exudative maculopathy. And presence of a ellipsoid zone discontinuity or a ELM disruption also indicate a poor response to the treatment. Thus, OCT in diabetic macular edema give lot of information regarding the from diagnosing the disease, regarding the severity of the disease, some clue regarding the systemic condition of the patient. So it plays a very valuable role in management of DME. Thank you.
Thank you, Dr. Sharath. Any questions anybody wants to ask?
Do we generally laser the hard exudates all that often?
If it is a focal maculopathy, you can definitely see a aneurysm.
Yeah,
you can leak it.
that
If it is
case.
encroaching the fovea, you can laser it.
When you have a pearl necklace sign,
Yeah.
but at the same time it's involving the center,
Yeah.
you have a rationale of putting injections or not? Because you said it's chronic.
Yeah, go for injection. If it is a center, later it can form hard exudates clump there. So it's better to treat it.
Okay, that's all. We can move on to our next presentation. Thank you, Dr. Sharath. Now, fundus fluorescent angiography, with the advent of multimodal imaging, our age-old FFA is sometimes underrated. But FFA has got very important clinical uses in diabetic macular edema. Dr. Parvati will be elaborating on the relevance of FFA in the current scenario.
Good morning, all. Today I will be talking the relevance of fundus fluorescent angiography in diabetic macular edema management. So, FA is a diagnostic procedure where a series of photographs of both eyes are taken after injecting sodium fluorescein intravenously. And as we know, it has various phases like the choroidal phase, arterial phase, early AV phase, late AV phase, recirculation and late phases. Does FFA still have a role in diabetic retinopathy and DME management? Or can we just treat based on the OCT or OCTA and clinical correlation alone? The answer is yes. FFA still has its own role in diabetic macular edema management, and it is considered in clinical practice for two reasons that might be difficult to obtain with any other imaging modality, that is ischemia and leakage. So, the role of FFA include to study the perfusion status of macula, to characterize the type of diabetic macular edema diagnosed on ophthalmoscopy and OCT, like whether it is having a focal or diffuse edema, whether the edema is perfused or non-perfused, and to investigate in a diabetic patient the vision loss which is incompletely explained by other modalities, that is to rule out macular ischemia. So, saying about macular ischemia, we should know about the normal foveal avascular zone. That is a hypofluorescent area seen in the fovea, and it is a capillary free zone of 350 to 500 microns in diameter present at the fovea, and this hypofluorescence is due to absence of blood vessels and the presence of xanthophyll pigments, and this is visualized in the late venous phase around 25 to 30 seconds of the fluorescent angiogram. So, in order to rule out macular ischemia, we have to look at the size of the foveal avascular zone, the morphology of the foveal avascular zone. The foveal avascular zone can be enlarged or distorted. And saying about the enlargement of foveal avascular zone, there is not a definitive cutoff for this enlargement, but always if it is more than 1000 microns, it is considered abnormal. We have to always compare it with the other eye. Normally it is around 500 microns in size, and we have to always check for the margins of the foveal avascular zone. If whether the margins are continuous or there is any break in the capillary network of the FAZ. And here we can see a case of macular ischemia, and the question is whether there is no role for macular laser in this type of ischemic maculopathy. Whether anti-VEGF and steroids can help, that is questionable. And can Octa replace FA? Actually, Octa is a very good tool to identify ischemia. But in case of diabetic macular edema, due to the edema and fluid, there will be errors occurring in the Octa segmentation, and also the capillary density will be falsely reduced in cases of edema. So, FFA stands better than Octa in diagnosing macular ischemia. Then we have the second role of FFA is to identify the type of maculopathy. To identify the type of maculopathy, that is whether it is a focal maculopathy caused due to microaneurysm leaking fluid into the retina, or if it is a diffuse maculopathy due to dilated retinal capillaries, or whether it is mixed, that is a combination of focal and diffuse. Here, focal leak, we can see in the early phases multiple microaneurysms are here, and in the late phases these microaneurysms are leaking, and if the majority of the leak, more than 2/3 of the leak is caused around the microaneurysm, it can be considered as a focal leak. And these focal leaks can be treated by focal laser if it is non-center involving. And FFA can be used, these images can be used to guide the photocoagulation of these leaky microaneurysms. And direct laser treatment can be applied to all focal points of leakage located between 500 to 3000 micron of foveal avascular zone. And if we are planning laser, we have to look at the relation of the leaky microaneurysm to the foveal avascular zone, and we have to avoid laser if it is within 500 microns of foveal avascular zone. Here we can see multiple microaneurysms in the early phase, and in late phase this microaneurysm, it is not leaking, and these aneurysms are leaking, and these are away from the foveal avascular zone, these are also leaking. And so the first one, since it is not leaking, there is no need for any laser treatment. And for the second one, it is within the 500 micron of foveal avascular zone, so we have to avoid laser. And in the third one, we can apply focal laser if needed. Then coming to diffuse leak, it is characterized by dilated capillaries which leak the fluorescent dye in the late phases, and according to ETDRS, the grid technique of laser can be applied to treat these diffuse leakages. And nowadays, if it is a DME center involving, we will treat it with anti-VEGF or steroids. Then this FFA can also used to assess the adequacy of macular laser treatment and the reappearance of edema, whether the leakage is caused by any new aneurysms. And another role of this FFA is in identifying pseudophakic CMA, that is in a pseudophakic patient with macular edema, cystoid macular edema, we have to always differentiate it from the whether it is caused by Irving-Gass syndrome or diabetic CMA. And in FFA, if it is Irving-Gass, we will get late stage petalloid edema, and the disc will be leaking in the late stages. And in diabetic CMA, there won't be disc staining unless there is a neovascularization of disc. Both of this will be having petalloid edema on FA, but based on the disc finding, we can classify, and treatment can be done accordingly. So to conclude, FFA is important at baseline to identify ischemia, whether the edema is focal or diffuse. FFA helps to plan the treatment, what to treat and what not to treat, and it has a role in pseudophakic CME, and FFA helps in assessing adequacy of laser treatment. That's it. Thank you.
Thank you.
Yes, ma'am.
Okay. Any questions? Now we have Dr. Vinita who will be presenting on OCT angiography. So we everyone have OCT, but in this era, that OCTA is one thing which actually helps when people don't have fluorescein angiogram, because all the vascular plexus of the inner layer, and this is actually useful for the diagnostic and prognosticating the diabetic macular edema. So Vinita will be talking on OCTA, a helping hand.
Thank you, ma'am. So, okay. OCT as a helping hand in diabetic macular edema. Now, OCT angiography is a non-invasive imaging modality used to visualize the retinal and the choroidal vasculature. It is basically dependent on the laser reflectance from the surface of moving RBCs. We take sequential scans along the same line. Then you analyze the difference between these scans for points of constant points and moving points. The points of movement are identified as flow, and all these points of flow are aligned together to create a vascular image. That is what we see as OCT angiography. Now, what are the advantages of OCTA over a conventional FFA? First of all, it is non-invasive, much quicker, no dye is required. Then, as there is no leakage, you get good structural detail of the vessels. 3D images are possible, unlike the 2D images in FFA, and you can segment into slabs. That is, the superficial and the deep layers can be separately visualized. And next is, since there is no leakage, you get a good quantitative analysis, which is important for research and clinical trial purposes, etc. If you look at the layers of the retina, you can see there are certain capillary plexus intermerged between these layers, and these are the layers that are actually segmented and studied in OCTA. The first two layers, the superficial capillary plexus and the intermediate capillary plexus, together form the superficial vascular complex. Then you have the deep capillary plexus forming the deep vascular complex. It is the deep plexus which is more important, because most studies have shown that ischemia of the deep vascular plexus is more associated with diabetic macular edema and the ischemic maculopathy. Now, OCTA is an optical imaging technique. It is motion sensitive, so inherently it is associated with a lot of artifacts. Particularly in DME, because there are cystoid spaces in the retina, segmentation errors are very common. As already mentioned, one of the important reasons why we cannot assess the perfusion clearly in an OCTA is because of the segmentation errors. So when there are segmentation errors in the segmentation created by the machine, we may have to manually correct it. Once the segmentation errors are corrected, what we are looking for mainly is the foveal avascular zone. Then you will have to differentiate between a cyst and a non-perfusion area, because since there are a lot of cysts, the cyst can cause mechanical movement of the vessels, the displacement of the vessels, and it can also shadow the underlying structure. So a cyst can appear as a non-perfusion, leading to a spuriously high FAZ value. Then microaneurysms are also important. I'll come to that. Now, regarding segmentation errors, it is a frequent artifact in macular OCTA images of DME. Manual correction of segmentation errors has been shown to significantly affect OCTA-derived measurements. However, manual delineation of all B scans is time consuming and it is not feasible in clinical settings. So, what is the solution we have? This is one study in which they have studied the segmentation errors. What they have found is most of the errors, they occur at the level of the inner plexiform layer. So if you can manually correct the inner plexiform layer at the foveal center and apply it to the rest of the scan, you can correct most of the errors associated with segmentation. So what they've concluded is that manual segmentation of retinal layers, particularly the inner plexiform layer at the foveal center, gives reasonably accurate OCTA measurements such as vessel density and foveal avascular zone area in clinical settings. However, this is not applicable in a research or trial situation where you need accurate measurements. Now, in the left side picture, you can see the blue line corresponds to the automated segmentation generated by the machine. You can see that it is cutting through the cyst. It is not correctly aligned along the inner plexiform layer. The other picture, you can see we've manually segmented and aligned it along the inner plexiform layer. The difference it makes is, this is the OCTA image that is generated by the first segmentation. The foveal avascular zone in the deep capillary plexus is what I've shown. After manual segmentation, there is a considerable decrease in the foveolar vascular zone. So that helps us to correct some of the errors that are caused by segmentation. Now, once you've corrected the segmentation errors, you're looking for the parameters on FA. Some of the machines give automated measurement values. In some of the machines, you will have to do it manually. Advantage over FFA is that you can assess it both in the superficial and the deep vascular plexus. In FFA, primarily, you are able to see only the superficial plexus. Now, what are the main parameters you are looking for? First is the FAZ perimeter. That is a line drawn along the innermost aspect of the vessels in the perifoveal area. The area within this perimeter will give you the foveolar vascular zone area. Then there is something called the circularity index, which is derived from the longest horizontal and the vertical diameters at the FAZ. It actually gives you an indication of how circular the fovea is. Several studies have shown that even with normal foveal avascular zone area, loss of circularity or irregularity of the FAZ is a sign of impending ischemia. Then other vessel parameters like vessel density and mean vascular flow density, that is based on the perifoveal vessels in the foveal area. Now, how do you differentiate between a cyst and a non-perfusion in an octa image? Now, a non-perfusion area typically has an irregular outline and it is bounded by the surrounding vessels. The inner aspect of a non-perfusion area, rather than being black, it is light gray. Whereas a cyst is a regular ovoid structure and the inner aspect of a cyst is black rather than a light gray. So this you can, when there is a segmentation error and you are actually cutting across a cyst, if you see these regular ovoid spaces, you can assume that it is cyst and not an actual non-perfusion area. Now, microaneurysms, generally low flow microaneurysms are not detectable on octa because it is based on the flow of blood in the blood vessels. However, perfuse microaneurysms, which are hyperreflective, or high flow microaneurysms, can be detected in octa. And these are the microaneurysms that are actually associated with an increased risk of localized edema and even ischemia. Now, this is an interesting study where they've studied the OCT angiography of DME and its association to treatment response with anti-VEGF agents. They actually classified the patients into two groups, responders and non-responders. This is an example of a responder. You can see the left side OCT image is the pre-injection, right side is the post-injection, and they actually measure two parameters, that is the foveal avascular zone and the microaneurysms identified on octa in the superficial and the deep capillary plexus. This is the superficial, this is the deep. Okay, and these yellow circles are actually the microaneurysms detected on octa. This is a microaneurysm. Non-responder group, again they've studied the superficial and the deep plexus. What they have observed is that this is again the foveal avascular zone. The left side image is the responder group, the foveal avascular zone, and the non-responder group, the irregular foveal avascular zone. What they have identified is that in all patients with DME, whether they are responder or non-responder, there were more microaneurysms, larger area of foveal avascular zone, and lower mean vascular density in the deep vascular complex compared to the superficial vascular complex. In addition, what they've seen is that in non-responders, more microaneurysms, larger FAZ, and lower mean vascular density were more prominent in the deep vascular complex, but the difference in the superficial vascular plexus was not significant. So which means ischemia and non-response are all associated with ischemia in the deep vascular complex rather than the superficial. Now, to take home, though we speak a lot about octa, we should understand that it is not a mandatory investigation in all cases of diabetic macular edema. Vascularity of the deep vascular complex is an important prognostic marker, and the best way to assess the vascularity of the deep vascular complex is octa, provided it is properly captured and systematically interpreted, and it is a valuable tool in estimating the visual prognosis and helps in decision making in case of non-responders. Thank you for your patient listening.
Thank you, Anita. So, any questions?
OCT or Opta. In a busy practice, very often we do not have time to go and check. But like Madam said, all that segmentation is very important. And scrolling through the images that's been taken helps us to identify a lot more things that we might miss by just looking at a final printout.
In fact, the morphology is more important than the quantitative analysis. So most often we look at central macular thickness. It is actually overestimated, but morphology of the edema will be more important. The biomarkers are more important than the actual measurements.
Definitely, this Octa proper evaluation is time consuming. So probably one situation where I use Octa in my diabetic patients is when the patient is not having any macular edema, either before treatment or after treatment, and I cannot explain the loss of vision. So when there is a lot of cystoid spaces, you are definitely going to you're not going to properly interpret the amount of ischemia. Maybe more this machine learning, deep learning, everything will come out with an answer for this.
Especially in those patients, with most of those patients, actually the creatinine levels are so high. And it is so cumbersome. Actually, you have to send the patients to the nephrologist and all. And one way or the other, they are always against us with injections and all. And what to say? That with angiogram itself, they'll tell like it's better not to. So this is actually, it's a boon for such kind of patients. Okay. Any other questions? Okay. Now we have Dr. Rajesh. Okay, so this our industry is bombarded with lots of anti-VEGF, and you can see the stalls and talking to us regarding all the biosimilars and all, and they are hitting from right and left, asking us to inject and all. So Dr. Rajesh will be talking on making the right choice, like which injection is best and when to do it. Okay, over to you.
Thank you, Dr. Vinita and Samira, for this opportunity. I'll be talking about the making the right choice of intravitreal injection in patients with diabetic macular edema. We know that the treatment for center involving diabetic macular edema is with injections. We have a lot of injections available in the form of anti-VEGF as well as steroid injections, and more injections are in the pipeline. So as of now, what is our current understanding of diabetic macular edema and how we can use the present the available injections in the treatment of diabetic macular edema? That is what I'm going to discuss now. So what is the pathophysiology of diabetic macular edema? So it is mainly because of hyperglycemia. We see release of inflammatory cytokines and growth factors which lead to breakdown of the blood-retinal barrier. And what is important to understand is that it is not just VEGF that is responsible for diabetic macular edema. There are also many inflammatory mediators that are involved. So we know that we treat most of the patients, or we are with the mindset that we treat all the patients with anti-VEGF injections. But then anti-VEGF injection does not work in all the patients because there are other mechanisms that are acting in that particular patient that he is not responding. That is the reason why he is not responding to the anti-VEGF injection. So we have to think about options other than anti-VEGF, or agents which have got more, which take care of most of the inflammatory mediators also along with VEGF when you are treating a patient with diabetic macular edema, especially the patient is not responding to the treatment. So there have been various trials. Most of the trials, they look at the visual outcome. They actually do not look at the anatomical outcome. Most of the trials say that if you give this particular injection, you can have this good visual outcome at the end of 1 year or 2 years. So we are not actually looking at the anatomical outcome. So what has been observed in most of the trials is that the patient is not experiencing a good visual outcome at first 3 months, that they are not having an improvement in vision by at least 5 letters on ETDRS chart. These patients are likely to have poor visual outcome at the end of 1 to 3 years. Similarly, if you look at the patients who are having anatomical response, not all we might have seen, all of us might have seen that even if after giving repeated anti-VEGF injections, many patients, they continue to have cysts and subretinal fluid and increased thickening. And these patients who do not have a good anatomical response to the first 3 injections, these patients are again likely to have persistence of macular edema at the end of 1 to 2 years, or even at 3 years. So what has been observed is that when you look at the visual outcome and when you compare it with the anatomical outcome, it has been observed that those patients who have a persistent macular edema, they are likely to have poor visual outcome. So it is equally important, rather than just looking at the visual outcome, it is also equally important to have good anatomical outcome, to have a good visual outcome. So, the most important component of the fluid that we look for in a patient with diabetic macular edema is the presence of intraretinal fluid, because the presence of intraretinal fluid, or for a persistence of the intraretinal fluid over a period of time, can lead to destruction of the connections between the photoreceptors and ganglion cells in the neuroretina. So that is why when you are not getting good injection, good response, anatomic response with few injections of anti-VEGF, we should not, most of the trials say that you give 6 injections, 7 injections at a, and then wait. It is not prudent to wait for anatomic response or improvement in vision for more than 3 injections. Most of the studies now recommend that, most of us now have started giving injections, or start changing the injections or shifting to steroids after the patient does not show any response after the first 3 injections. Now let us look at a scenario where the patient is having 6/6 vision. So when a patient has got 6/6 vision, should we treat the patient or not? This was evaluated in the protocol V of DRCR.net trial, and they found that whether you observe this patient, whether you treat the patients with aflibercept, or whether you do a laser photocoagulation, the number of patients who had a 5-letter drop in vision at the end of 2 years was same. So what we can understand is that a patient who is having 6/6 vision, you can actually observe the patient. You need not give any injection to the patient unless there is a deterioration of vision. Now, should you treat a patient with 6/6 vision? Yes, there are situations where we will have to treat the patient with 6/6 vision, because if the patient is symptomatic, some of these patients, they will be having the cyst right at the center that can impair the entire vision. The quality of vision may be affected. They can have micropsia, metamorphopsia, macropsia, etc. Then that is one situation where you have to treat the patient. Then if you're planning cataract surgery or laser, so know that after cataract surgery, there is a release of a lot of inflammatory mediators following the surgery, so there can be a worsening of the edema following cataract surgery. So you should treat the patients even if the vision is 6/6. Some of the, see, nowadays we are doing cataract even with a good vision. So even with 6/6, you inject the patient with some intravitreal injection just before the surgery. And if you're planning panretinal photocoagulation, so after panretinal photocoagulation, there can again be worsening of the edema. So to prevent that, you can give an injection in addition to the laser. And if the patient is unlikely to be compliant, the patient, especially the patient is sick, he is not able to come to the hospital very frequently, then we have to treat the patient. Then another important OCT biomarker which says that you have to treat the patient even with 6/6 is when the patient is having subretinal fluid. Because Sharath had shown his presentation is that the most extreme form of diabetic macular edema is when you get subretinal fluid. Then anti-VEGF of choice, if we are thinking that you will, most of us treat the patient initially with anti-VEGF injections. So if the patient is having a vision better than 6/9 or up to 6/12, what is your treatment of choice? So protocol T found that if you are going to give treat these patients with either Avastin, aflibercept, or ranibizumab, they are all likely to have the same visual outcome. So a patient with vision between 6/9 and 6/12, we can treat the patients with any of these injections. But if the patient's vision is less than 6/12, it was observed that during the first 1 year of the treatment, those patients who received aflibercept, they had a better visual outcome compared to ranibizumab and bevacizumab. But at the end of 2 years, the difference between the aflibercept and ranibizumab was nullified, and only those patients who were on bevacizumab, they had a poor visual outcome compared to aflibercept. In fact, there was not much of difference between aflibercept and ranibizumab. So if a patient is having a vision less than 20/40, we should be treating the patient with either aflibercept or ranibizumab based on the protocol T data. So again, if you look at the protocol T anatomical outcome, you can see that the reduction in central retinal thickness was better with aflibercept compared to bevacizumab. And it was also better with ranibizumab compared to bevacizumab. So it shows that there was not much of difference between aflibercept and ranibizumab. So around 29% of patients on aflibercept, 39% on ranibizumab, and 59% on bevacizumab had persistent diabetic macular edema at 2 years in protocol T. So probably the poor visual outcome in the bevacizumab group, that explains the poor visual outcome. The persistence of the macular edema in the bevacizumab group probably explains the the poor visual outcome in patients who received bevacizumab injection. So it just again emphasizes the factor that the resolution of macular edema or anatomical outcome is equally important to have a good visual outcome. Now we see some of the patients who present to us with this kind of picture. We see a lot of hyperreflective foci. Sharad told us about hyperreflective foci. These are very hyperreflective dots which you see in the different layers of the retina, and they do not have any back shadowing. So if you see hyperreflective foci, if you see subretinal fluid, and also they have a lot of hard exudates, then you can also think about a different line of or initiation of treatment can be done with steroids, because hyperreflective foci as well as subretinal fluid, these are considered as biomarkers of inflammation. So inflammation responds better to steroids. You can also treat the hard exudates when there are a lot of hard exudates are present. Once you take care of the dyslipidemia factor, you should also be treating this patient with steroids, because with steroids it has been shown that most of the hard exudates melt away once you start the treatment with steroids. So patient having hyperreflective foci, SRF and hard exudates, steroid may be a good option to initiate the treatment. Now, the reason why we are always talking about anti-VEGF injection as the first line of treatment in diabetic macular edema is mainly because of the complication associated with the steroid injection. Because with the steroid you can have cataract, and with steroid you can also have glaucoma. But when we look at when we look at our own data in our clinical practice, we see that even if the cataract develops, once you treat the cataract, these patients are likely to have good visual outcome if their macular edema is taken care of at an early stage. So just delaying the resolution, a good anatomical amount, by not giving steroid, even after the cataract surgery, you may not get a very good visual outcome. So if you are planning, if you expect the patient to get good visual outcome, you should be able to reduce the macular edema at an early stage. So and nowadays the cataract surgery is all very fine and very refined compared to the early days. So I think that steroids should be given at an early stage and should not wait for a long time before we switch from anti-VEGF to steroids if you are planning a good visual outcome in these patients subsequent to the cataract surgery. Now, some of the patients, they can have a combination of diabetic macular edema and proliferative diabetic retinopathy. So if we give anti-VEGF injections, usually it takes care of both the components, the neovascularization as well as the macular edema. But again, when you are looking at a patient with a combination of diabetic macular edema and PDR, make sure that the patient does not have extensive neovascularization. There is a lot of neovascularization. Then by giving an anti-VEGF injection, you can actually lead to an angiofibrotic switch, which leads to extensive traction on the retina. And a patient who is having a fibrovascular or just a neovascularization along the arcade, after the injection, because of angiofibrotic switch, there can be a traction, worsening of the traction, which can lead to a traction retinal detachment involving the macula. So just because the patient is having PDR and diabetic macular edema, don't always think that you are going to treat the patient with anti-VEGF injection. You should also take into consideration the extent of neovascularization and treat the patient properly, the macular edema, with steroids, and then you do fractionated PRP to prevent a sudden angiofibrotic switch. So when to consider switching to steroids? So from what I have told you, now we know that when the reduction, there is no significant reduction in the central retinal thickness during the first 3 months, or there is not much significant improvement in vision during the first three months. If the patient cannot afford a stronger anti-VEGF injection, then we should think about switching to steroids. And at a later stage, if during the second year of the treatment, if the patient is still on anti-VEGF injection, and during the second year the patient has received more than 6 anti-VEGF injections, that means again the patient requires treatment with steroids. And there are certain situations where we use steroids as the first line, especially a recent MI, CVA, advanced nephropathy, and before cataract surgery, as well as in vitrectomized eyes. In vitrectomized eye, the steroid of choice will be a dexamethasone implant, which stays in the vitreous cavity for a longer time. Now we have more stronger anti-VEGF injections now available. The need for stronger anti-VEGF injection is first again to have much better anatomical outcome. More than that, stronger anti-VEGF injections, they helps us to reduce the number of visits the patient requires for the treatment of diabetic macular edema. Because if you look at brolucizumab as well as faricimab, it has been observed that these patients who receive the treatment with brolucizumab, almost 50% of the patients, they can be maintained on 3 monthly injections. So one reason why the treatment for diabetic diabetic macular edema fails in most of the patients is the requirement for frequent injections. So if you can reduce the number of injections by having an agent which has a prolonged duration of action, then that is going to ensure a good visual outcome. So that is why we should use brolucizumab or faricimab in patients with diabetic macular edema, especially if you want to reduce the number of injections and to increase the compliance. But the problem is that these are all very expensive injections. So from the trials with the faricimab, it has been observed that these patients, they achieve same visual outcome compared to aflibercept with fewer injections. Same, the number of patients who had complete absence of diabetic macular edema was again achieved with a few number of injections with faricimab compared to aflibercept. So it is even stronger than aflibercept. To summarize, diabetic macular edema is not solely driven by VEGF. You should always think about other inflammatory mediators. And if the patient is having persistent edema, after 3 injections, you should either switch to a stronger anti-VEGF or a steroid. Thank you.
Thank you, Rajesh. Any questions?
Yes, maybe you should. Most of the time, the steroids, they work for around 2.5 to 3 months. So when the patient gets a recurrence, we repeat the injection. And always see the other things like whether the patient is having glaucoma or not. Otherwise, there is no problem. Even when there is a glaucoma, if it is controlled with anti-glaucoma medications, still you can repeat the injection. And always get it evaluated by a glaucoma person to make sure that there is already no visual field defect has happened.
Just for a discussion, like suppose it's a large macular edema, like 700 microns in a phakic eye. So will you be hesitant to inject a DEX implant, or you want the patient to start with, suppose the patient is coming with all these inflammatory markers and all, like so many inflammatory markers, and also what will be your choice? Like will you be going ahead? It's a phakic eye.
Even in the presence of all these inflammatory markers, the first line of treatment is usually anti-VEGF injections only. But unless there is a contraindication for use of anti-VEGF injections, unless there is no contraindication, then only when there is a contraindication for anti-VEGF injection, most of the time I start with the steroid injections. But okay. But that is why I'm saying, because just because you think that the patient is going to develop cataract, you should know that you can give 3 injections, see whether it is working. If it's not, then immediately switch to steroids.
If given a choice, like the cost is not a factor, so which anti-VEGF will you prefer?
I will say maybe faricimab, because it has got dual mode of action. It is not just blocking the VEGF, it also has angiopoietin 2 inhibition. So angiopoietin 2 inhibition is also supposed to prevent inflammation. It's not just anti. So angiopoietin 2, the advantage of faricimab is that it blocks VEGF, it blocks the inflammatory mediators, and it also blocks fibrosis. That is why it is very good in CNVM patients also.
Okay, thank you, sir. Now we know that all macular edemas are not responsive to injections. That is when we need alternative methods of treatment. Dr. Samira will be elaborating on the role of laser and surgery in diabetic macular edema. Over to you, ma'am.
Good morning, all. Dr. Rajesh has made my topic much more easier. Actually, he have told regarding the cost of the injections and all. Okay, so I'll be talking on role of laser and surgery in diabetic macular edema. So ETDRS have put up an inference that macular laser photocoagulation is the primary treatment option for DME. But the EU-retina guidelines have told that laser treatment is no longer considered the standard care for DME in the current era of anti-VEGF drugs. But the real world data has telling us that relying solely on anti-VEGF injections may not be practical due to multiple factors like economic burden of the treatment, poor response to anti-VEGF, systemic conditions that limit treatment options. And the role of laser is still there. So we are doing focal laser for microaneurysms, we are doing grid laser for areas of diffuse leakage for the thickened retina. But what is the issue? So there is lots of scar of trophy and subretinal fibrosis in almost around 25% of the cases and all. So then we came across with the modified ETDRS where laser spots were slightly smaller and lighter. So laser in DME, there are multiple studies. The protocol A is telling that modified ETDRS was still an appropriate treatment for extrafoveal DME. The READ2 study compared the efficacy of ranibizumab with or without laser, so that has shown that combination therapy with focal or grid laser treatment has reduced the percentage of patients that require frequent ranibizumab injections. So the number of injections in the 2 year has come down from 9.3 to 2.9 in the combination group. So definitely there is a role for laser. So what do we deal with? We are injecting, we are re-injecting and again. So where is the issue? Okay, the surgeon is upset, the patients are upset. So what happens? The financial burden of DME and DR in injecting these patients, actually it is so much. So what do we deal? So it is just like your eyeball is becoming richer and richer day by day. So we deal actually not with the sick tissue, but with the anxiety and the emotional roller coaster. That is what we deal. So once you inject, so this is what we feel. So you can see after an injection, the vision is becoming okay and the patient is happy. And just after an injection, maybe 1 or 2 months later, and the visual acuity is coming down and the roller coaster is going again and again. So laser, it still has a role in the treatment of DME. Always should be combined with a good glycemic control, and laser need 2 to 3 months to take effect. You have to tell the patient that it is going to take time, not like an injection, because most of the patients usually comes and tell that, okay, after laser my vision is just the same. It's not like the injection and also you should definitely convince the patient that it's going to take time, and the effect can last up to 18 weeks. Now, there are different types of lasers like machine, methods and modes. So the suprathreshold burns was with the conventional laser. Then the modified ETDRS, we came up with the barely visible burns. And now we have the subthreshold burns with the micropulse laser. Now we have navigation laser and the other ones are the selective retinal laser. So this is a chart. We can see that there are different types of laser and the disadvantages associated with it. In the navigational laser, you can see it evaluates the laser only via live monitor. And the disadvantage of micropulse laser is whenever there is a central thickness of more than 400 microns, you cannot treat a diabetic macular edema with a micropulse laser. And the rest of the ones, the laser devices are actually, it is limited, so it is yet to come. And now the modified ETDRS photocoagulation which we use right now, so the disadvantage is no treatment can be placed within the 500 microns. So then came the micropulse laser. So what is this micropulse laser? It is just like chopping off the laser. So what you can do is that the tissue is getting cooled in between whenever you are using the micropulse laser. So you have to make it sure that focal treatment of this microaneurysm is not at all a strategy for micropulse laser. It is for the diffuse edema. So here what happens is that you are actually amplifying and maximizing the laser by simply giving a confluent and a contiguous laser spot, unlike the modified ETDRS one where we are putting the lasers in two laser spots apart. Here, so it's just like painting the macula over the entire area of the retinal pathology. So what happens is that it works by normalizing the RPE function. And then comes the navigated laser system. So this is a technology that incorporates a retinal eye tracking laser delivery system with an integrated digital fundus imaging. So you treat retinal lesions by overlaying the images onto the live image of the retina. So what happens in this navigated laser system is, you can see over here, it's a video. So what you do is in this live image, you are actually marking the disc as well as you are marking the fovea. And accordingly, you are marking the area of the retinal pathology, whatever be the lesion. And you are actually titrating the dosage. And you can see over here how the laser has been done. So it's so simple. So the accuracy of tracking these microaneurysms and hitting the microaneurysms, unlike the ETDRS, is actually it's more than 30%. So that's the advantage of the navigated laser systems. Now, when should laser be applied in DME? As a first line. So we can do in non-center involving CSME cases, and even we can do in central DME patients with good vision. when the baseline is better and when the patient is having a good glycemic control. But this can be done with a micropulse laser only when the central retinal thickness is less than 350 microns. And for patients with recent stroke, ischemic heart disease, or with high cardiovascular cases and all, and whenever the intravitreal injections are contraindicated, and for patients who decline intravitreal injections. So what about the second line or the adjuvant therapy? So when the DME is not responding based on OCT even after 4 to 6 injections, as Dr. Rajesh has mentioned, multiple anti-VEGF injections, and you have given 2 to 3 intravitreal steroids, definitely you have to think about laser. And second one, the most common scenario is an adjuvant therapy to intravitreals whenever retinal thickness is less than 400 microns. After injecting, keeping on injecting, and the edema has come down to 400, don't wait for another, the edema to increase and go for the second injection or third. Reduce the number of intravitreal injections can be done, and the delay of interval of DME recurrence can be done with an adjuvant laser. Now, this is the non-center involved diabetic macular edema. The central subfield zone is not involved. So these are few cases I will show you with a conventional laser. It's a 56-year-old male with BCVA 6.9. You can see 3 months later how beautifully the edema has come down. And microaneurysms, it's a large perifoveal microaneurysm, can be seen in 1 month after laser, and 3 months after laser the edema has subsided. Conventional laser, modified grit laser can be given for the diffuse edema. You can see the marks. And what about micropulse laser? So this is a case of 61-year-old female with post-Ozurdex with multiple anti-VEGFs, almost like 16 or 17. So the patient was very reluctant for injection again when her vision dropped to 6/12 and all. So we have done an entire macular painting with subthreshold laser, and 5 months later the edema started coming down. Now, injection deferred cases. This is one case which is very close to my heart. Actually, like, this patient is under treatment with me since the past 4 years. 37-year-old male, BCVA 618. He's due for his renal transplant. He underwent post-angioplasty twice in 3 months, and still there is a large block is there. You cannot take this patient up, and you can see almost the traction is there towards, extra macular and all. So the edema is still there. It's a one-night cases and all. So such cases and all, you can actually plan for laser. Now, DME, already they have told about the tractional DME and non-tractional DME. So non-tractional DME has already been discussed widely. Now, what about the tractional DME? So tractional DME, always considering the vitrectomy is the best option. So whenever there is a focal vitreomacular traction, it's better to go for a vitrectomy. And if you have a broad vitreoretinal adhesion, you can treat the central involving edema, and once the response is very poor, you can consider taking up for a vitrectomy. And when there is a diffuse diabetic macular edema, suppose if the treatment is failing even after multiple injections, even with rescue treatment, you can plan for vitrectomy with ILM peel. Now, why we need vitrectomy? So how the vitrectomy is going to help us? So vitrectomy remove the tractional forces at the retinal surface. It reduces the oxygen consumption of the vitreous by removal of the vitreous. It reduces the hypoxia. It removes the vitreous collagen on the retina, so which has a potentially high concentration of VEGF. And ILM peeling itself induces the glial repairing process. This is how vitrectomy helps in diabetic macular edema. But you should be very meticulous. You should be very careful to choose such cases for a vitrectomy in a case of chronic diabetic macular edema. Why? Because if the initial visual acuity is poor, there's a poor prognosis. If there are ISOS defects, if there are breaks in ELM, and FFA is showing presence of ischemia, and you can see an optic disc over there which is very pale, these are not good cases for a vitrectomy. So such cases like proliferative DR with tractional DME, you can just do for a filling laser, and it's always better to take up such cases for vitrectomy. So this is one video you can see. Thanks to Dr. Prakash, when I have lost all my videos, I had asked to get one video from him. So you can see how the vitrectomy is being done. I'll just quickly forward it. PVD induction has been done. And you can see there is a BBG stain has been done, and this is the taut posterior hyaloid. So you are removing that first, and double staining, and then we are peeling off the ILM. Okay, so the take-home message is the laser still holds on. And whenever you see this kind of picture, like all CME is not DME, This is a case like who has taken injections, around some 5 injections from a prestigious institution, and later on they have come to know that this is not DME. Somehow this patient was injected 6 times. So this is not DME. Thank you.
Thank you, Dr. Sam.